Patient flow, according to the IHI, patient flow is defined as an individual's movement through and around the healthcare continuum. And if you look at what Accreditation Canada is now doing, they've identified, as all of us in this room will know, ED overcrowding is a system-wide challenge. Its root cause is usually poor client flow. And moving into January 2015, Accreditation Canada is going to be looking at the accountability of senior leaders, including physicians, to ensure that there's a focus on this within those organizations that are having these challenges. So Accreditation Canada in January 2015 is going to be looking at how hospitals and your surrounding healthcare partners are actually moving forward to ensure that we're focused on access and flow and making improvements to ensure that we're addressing the challenges that face us. So I want to just talk a bit about one particular patient, Anne. So Anne is a fictional character, but living with substance abuse, bipolar disorder, asthma, type 2 diabetes, COPD, so a number of comorbidities. Has a family health care provider, but has visited the emergency department 69 times in the last 12 months. So even though Anne is a fictional character, we do have patients that fit this description of coming to the emergency department that many times in the last year. So how are we at the Southwest LHIN measuring patient access and flow? There's a number of things that we're focused on now to ensure that we're looking at these areas and making improvements and monitoring if we're doing the right things to improve access and flow across our region. So this is a continuum of Anne's life. So you start up in the top left corner, she's living in the community, moves into the emergency department, and moves into acute care, and then finally in the lower left, living in the community post-acute care. So what are the things that we're doing to monitor and measure patient flow in the emergency department? Reducing readmissions within 30 days for COPD and other similar concerns. And increasing discharge summaries sent from hospital to community and family health care within 48 hours. We've been doing these physician engagement sessions for a number of years now, probably 7 or 8 years, and a consistent theme from the primary care physicians that are in the audience are that the patient comes to their office and they may not know that they're even in hospital. So we need to ensure that those discharge summaries are getting from the hospital to the primary care physician. They know what course of care that patient received. And finally, increasing the percentage of patients seeing their family health care within 7 days of discharge. So again, a very important indicator when you're looking at readmission rates, ensuring that when patients are discharged from hospital that there is that follow-up from primary care. And this is not, it's a system-wide responsibility. It's not just something that we hang on primary care or on the hospital. It's all the partners working together to ensure that care is provided within that 7 days of discharge. So, what's the burning platform for change? Again, using Anne's healthcare experience. This is not Anne's data, but this is for London Health Sciences Center, and I'll show you some, I'll drill down on some of this data. In the emergency department, Anne spends 32 hours in the emergency department. Anne is admitted to hospital with exasperation for COPD. She spends 23 hours in the ED waiting for an inpatient bed. And I'll show you this data, it's quite interesting. After her acute episode, Anne is discharged and readmitted 10 days later for similar complaints. Approximately 22% of the time patients with COPD are readmitted within 30 days. And finally, Anne tries to get an appointment with her family health care provider. It's in 2 weeks, and we know across the Southwest LHIN that only 38% of family health care, or see their family health care within 7 days across the Southwest LHIN. And again, the bottom part of that box, the doctor has no idea that what care was received within the hospital. Only 33% of primary care physicians receive that discharge summary within 48 hours. So this pulls together a number of issues that we see across the system that we'd like to talk about, and we can give you some of the focus that we're working on tonight, but interested in your feedback and comments around this as well. So I said there's some further dialogue or further data. Two of the things that I'm going to show to you tonight is the time to inpatient bed for the London hospitals as well as for some of our surrounding hospitals, and ICU avoidable days, which I know Mike is going to speak to tonight. So I'm not sure how well you can see this data. So this is admitted patient time, so the wait time for a patient to be admitted when they present at the ER. Hospitals are along the left-hand column, so you can see University of Victoria, St. Thomas, Sound. Those are all pay-for-results hospitals, so hospitals that actually there's some financial incentive for them to improve their performance. The bottom four hospitals, Stratford, Tilsonburg, Strathroy, and Woodstock, are knowledge transfer organizations. So these are hospitals that we're working with to transfer knowledge and education from those hospitals that are performing well into some of the other hospitals across the region. So moving across, there's 2 years of data here. University Hospital, you can see that the wait time for an admitted patient in the ER in 2012-2013 was 30.1 hours. And then this current year to date, it's 32 hours, so it's actually increased 6.3%. We move to the next set of columns, and this is the time to inpatient bed. So this is a subset of that earlier number. So the total amount of time that they spent waiting to get admitted was that if we use 32 hours in the 14-15 year. 23.4 hours of that 32 hours was waiting for an inpatient bed. So they had their assessment, their diagnostics, they were ready to go, ready to be admitted, and there was a 23-hour wait before they could actually access that inpatient bed. So in this case, in University Hospital, you can see that the numbers have actually declined from last year to this. But in most of our other hospitals, including Victoria, the numbers are actually getting better. So we've seen a 15% increase or improvement in that time to inpatient bed. Victoria Hospital in St. Thomas, it's gone from 1.4 hours to 1, so 28.6% improvement. But if you look across our LHIN, you can see where the challenges lie at the London hospitals. So that wait time for admitted patients, time to inpatient bed are considerably higher than in most of our other hospitals across the region. And we are making great strides in other hospitals. Woodstock's a great example. If you go along the bottom column there, for their wait time for their admitted patients, it's gone from 12 hours to 8.4 hours, and then for time to inpatient bed, it's gone from 4.4 hours to 1.9. So there are areas that have been successful in, when I say we, the system has been successful in making improvements, but there's still more challenges that lie ahead. I won't spend a lot of time on this, but what it shows, this is the ICU avoidable days. So an ICU avoidable day is a day in the ICU when a patient no longer medically needs the ICU and they're looking for the next destination. You can see it's declining slightly over since April 2013 to September 2014, but still 8% of those beds are avoidable ICU days, so those patients actually should be elsewhere within the system. And again, I know Mike is going to speak to that tonight. So what are we doing about improving flow within the Southwest LHIN? We've identified some of the challenges. You're going to hear tonight about 4 specific ones. Emergency Department Mental Health Access, so Dr. John Dreyer is going to speak to that issue tonight. How do patients access the Schedule I beds in the mental health system across the acute mental health system across the Southwest LHIN? You're going to hear about e-consult from Dr. McFadden. We're one of 5, I guess, pilot projects across the province. St. Joe's and LHSC, so interesting piece there. Dr. Mike Sharp, who's our critical care lead, and you're going to hear about critical care access and flow initiative. And then Dr. Scott McKay and Donald Laddiser from CCAC. Scott is one of our primary care leads, are going to talk about discharge planning. So 4 areas where we're going to talk about how we're addressing some of these patient flow and access issues. Just before I wrap up, I want to give you some idea of what tools we have available to us to help make some of these decisions. Hopefully some of you, or most of you, have heard about RIDS, the Regional Integration Decision Support System. It's a warehouse that links data together. So it actually brings data together from OHIP, from NACRS, all kinds of different data sources so that you can track an individual patient through the system. And I'll show you a chart on the next slide. The second tool that we have is Clinical Connect. And Clinical Connect is a viewer. And I know when a LHIN CO gets up and starts talking about e-health and technology, everyone kind of rolls their eyes. But Clinical Connect is actually working well in the Hamilton, Niagara, Halton, and Brant LHIN. So it's not an EPR, it's not an electronic patient record, but it allows a physician or a clinician to look at different databases across the system. So it's a viewer of the data in different data systems. It's coming. The implementation process is underway. LHIN Health Sciences Center is actually leading this, and our local implementation partner is the Southwest Community Praxis Center. So this is a diagram of grids, what I referred to earlier, where we can look at different databases for a particular patient. So this is Anne. So if you look down, did Anne receive CHC's community health center service, medical daycare, same-day surgery, ED visits? That red line are actually X's. So those show, and this is a real patient, anonymized for the purposes of this presentation, but show where Anne has visited, or the number of times that Anne has visited since November 2013 to July 2014. The blue bars are acute admissions. So you can see Anne was admitted, a number of times are there, but a considerable number of times after coming to the emergency department. Mental health was obviously connected to the mental health system during that early stage of this diagram. And then CCAC service is the yellow line along the closer to the bottom. So we're just, the RID system is just started to get up and running.
Each one has inpatient mental health, or what's going on?
It must be inpatient mental health because I don't think it was community. I don't know for sure, but it have to be, I assume it would be inpatient. So again, the reason I show this tonight is to give you an example of the tools that we have available to us to look at some of these patients that make up that 5% of the population that consumes 66% of the resources. So that population that HealthLinks is focusing on, has been focusing on for the last few months and for the next number of years for sure. So what can primary care providers do to help? So I'm wrapping up here. Provide timely access to primary care, ensuring appropriate hours of service, communication of after-hours clinics, understanding which patients are frequently accessing the emergency department. So almost 200 physicians in the Southwest LHIN are using LHINs. I'm not that familiar with LHINs, so maybe we could hear more from Scott or others about the LHINs process, but it allows you to understand which of your patients are actually accessing the emergency department. 3, what I said about the referral process to specialists. This is something that we need to spend a considerable amount of time on to make sure that we make it better. Because right now, I don't disagree with Bob Bell or Dr. Poulter that the system is broken. Ensuring patients are seen within 7 days of discharge from hospital. So again, this is not something we're hanging on primary care physicians, but it means that primary care physicians have to know that their patient was in hospital and have the appropriate opportunity to follow up after that hospital course of care. Connecting to CCAC care coordinators. So all family physicians are connected with this. 90% of family physicians are connected with the CCAC care coordinator. Donald Lasser, who you'll hear from shortly, is we were up in the Owen Sound area meeting with the Owen Sound Family Health Team. And again, informing them that that person exists, that they should have that connection with them to ensure they've got the services they require. And then obviously maximizing the use of other healthcare providers such as MPs. So a list of things that we need to focus on, we the system, and you're going to hear more about that today as we go through the presentation.